Hello, everyone. It is Dr. Erkeda here. And for y'all who have been following me and those who may have been getting messages and things, you may have seen over the past few months, I've started doing a LinkedIn Live series talking about like the exciting things in health tech. So today we're in for a treat. We have the amazing Dr. Cam Matthews, and we're just going to be talking about some fun things. So, before we start, I guess we'll just do a little intro. So, you have quite a bio. You're a physician and a lawyer, the chief health officer of Cityblock, health innovation fellow, like all the things. So, we know this is a health tech. I don't want to call it a podcast, but it kind of is.
Right.
Let's just tell us a little bit about your passion for healthcare and healthcare technology.
Yeah, no, Erkeda, it's so wonderful to meet you. Thank you for including me. I love LinkedIn. So anytime we can actually have these conversations there, I'm always in. Um, let's see, my passion for healthcare, let me start there, definitely has been lifelong. I first and foremost wanted to be a primary care doc, a family doc at that, because of my sense of justice more than anything for communities that need better access, better services, better quality of care. I just wanted to be a part of the solution. I wanted to not just, however, do it for one patient at a time. I wanted to do it with scale, right? And so I work at the VA, now at Cityblock, just doing it at different scale, doing it with different populations. But then technology feeds into that. And admittedly, this is kind of a newer sort of interest and direction for me, is really about bringing even more creativity into the work that we do, finding different mechanisms for us to provide information, even treatment, ways to connect patients, to communicate with patients. Because, and this is the way I constantly am regarding kind of solutions in healthcare. Otherwise, we're just, within the definition of insanity, right? Doing the same thing over and over again and expecting a different outcome. Our healthcare system as it stands now, or, through prior generations, isn't working for all patients, and maybe working for some, but it's not working for all, especially when we're talking from an equity standpoint. And so I think technology, different payment mechanisms like we do at Cityblock, these are all just different solutions that we need to fully invest resources in, or otherwise we'll never really be able to help the patients that we're serving.
I couldn't agree more. And it seems like some of our paths are kind of coinciding. I too am a family physician, and I thought that when I left medical school and residency, like I'd be like a community doc for
Right.
like 30 years in a community health center. And I did that for a while. And then I kind of got the technology itch before it was cool in the pandemic, and people said it wasn't real to go into telehealth. But with the pandemic pushed us into different things.
Yeah.
So I definitely agree in terms of the newness, even though telehealth and digital health and everything has been around for a while, and these different innovations,
Exactly.
that we can't keep doing things the way that we've done them, because a lot of organizations are just doing everything that we do in person and just online and calling
Yeah.
that health tech. So we have to be innovative and think outside the box in order
Exactly.
to impact patients from a higher level. So that's
Exactly.
really exciting that you guys are doing that at Cityblock, and I'm sure we're going to talk a little more about that.
Yeah. I think there's such a hesitation, right, around whether technology, particularly AI, right, is going to replace us. And I think we can't afford to have that fear anymore. I think what the pandemic showed me, and many of us, you as well, I'm sure, is that there are opportunities to reach more patients, to reach communities, to bring about like the actual treatment, the actual services that we need. And we can do so without like, the brick and mortar sort of space. We can do so by reaching them, by sharing information, by thinking at a different level of how to actually even do so. And by a different level, I mean, it's not always the doctor that has to provide the information, right? We can have more broad approaches to public health even. We had to do that in COVID. It was every person on deck, right? To actually help us start the conversation around vaccines or about accessing emergency services or holding off on accessing kind of normal services because we needed to close the doors, right? Because there was fear of the virus. There's much, I think we need to get creative, and I think we need to bring a broader concept of what it is to be involved in health as opposed to just health care. And that's where technology, I think, can play a role. Why wouldn't it when we know we don't have enough workforce in the first place?
I love that. And you bring up a great point about like how there's so much fear about who's going to take your job and things. We've even seen it recently in the news where the San Francisco Kaiser nurses were a little afraid because they implemented some AI assistance to help the workflows and help people work to the top of their licenses. But they were afraid that it was going to, one, take their jobs, and two, kind of impact patient safety and patient care. What are some things that you think that organizations can do in order to alleviate those fears for our employees so that we can kind of all get on board?
This is all, I'm going to say bread and butter, but I know it's not that simple, so I don't want to oversimplify things. But this is bread and butter change management, right? Mm-hmm. How do we have any of our teams, any of our clinical leadership, operational leadership, to adapt to new workflows, to new programs, to a change in the EHR? How do we do that? Through change management, through involving them in the design, in the decision making, through having, champions on the floors, in the meeting rooms that are actually making the decisions about how we're going to roll this out, how we actually need to involve other persons within the decision making. I think part of the problem in the Stanford example is that was exactly what didn't happen. It was just decisions made, but the entire clinical teams weren't involved. I don't think the nurses in that case were involved in decision making at all. How dare them? Like, why wouldn't they be? And so I think when we're adopting new processes, first of all, there needs to be the users of the product and the processes involved in the design of it, but then they also have to be involved in the actual implementation towards execution. And I think that's our biggest problem. We try to do things at scale, but then we forget that the actual end users need to be appropriately involved.
I couldn't agree more. There are so many different ways and like little things that it happens throughout organizations, not just in healthcare, but especially in healthcare technology, where you're working in your silos and you have like the C-suite making all these decisions and you're not telling the worker bees. Like things could go so much more smoothly if you brought everyone aboard and you explain why. Like most people just want to like know why they're doing something and implementing things. And even when it comes to a lot of the things, like there are a lot of startups out there who are trying to implement healthcare. And they have the product team working in one silo and this person, the user experience.
Or
and
no users or clinicians involved at all.
So we have to bring them together because we're just going to just create these versions and they're going to be a mess. And then you're going to have to come back and fix it. So why not just start there from the beginning?
Yeah, and not just call us for advice on the product once it's made either, because I unfortunately have been a part of those conversations as well too, and it just doesn't bode well. It's as if it's a parallel example to creating products for marginalized communities, but not involving them in the actual design, the actual initiation of the ideas, but then expecting it to be successful by just handing it off to them and saying, well, now you have access. No, you don't.
No, you don't. And that's just a word of caution to leaders who may be building their groups. Like, bring us on early. If you're a startup, you talking about a healthcare company, probably the second or third person you need to hire is someone in medicine and use them as a partner and collaborate. Don't bring them on later.
Yeah. It's the same parallel. I often draw the same thing, the same example to clinical trials. So, you know, we're hoping to get more diversity and representation and clinical trial participation, but we're not even looking upstream. Are you finding more Black and brown investigators? Are you actually asking the questions and devising the solutions that will help specific communities, as opposed to just what's enriching, you know, your academic portfolio? So clinical trial participation, you know, tech design, I see it all the same, that if we're trying to target specific audiences, those audiences have to be involved from the very beginning. They have to have ownership in order for any of the design to be actually implemented appropriately.
Yes, and that definitely rings true for all things, including like diversity efforts. And if you want to implement equity into an organization, we need it all the way up to the board members, because if you're making these decisions and you have a board that does not look like the people that you're serving, you have some blinders on. It may be unintentional, but it's not going to bode well. So integrate the people that you're serving in these diverse experiences, whether or not they're people of color, people from diverse backgrounds, people, women, all of the things, because we need them.
Yeah, exactly. And not just for photos on your website.
That's the thing. So we started talking a little bit about AI and how people are afraid of it, and we're implementing it, and there seems to be a hot topic on everybody's conference. It's a thing, even though it's kind of been around for a long time. Machine learning isn't new. No. But the White House did just release a policy on AI governance, innovation, and risk management. How are you seeing this policy working to kind of transform the health tech landscape?
Yeah, I think it's the necessary beginning, but there's so many more steps. I think it's giving us some guide rails that will hopefully eventually get us to the point of some real collaboration. And, you know, I'm a part of a coalition. There's multiple ones popping up. But I think the federal government actually stepping in and recognizing that there needs to be some initial rulemaking around how we're actually approaching AI. I'm excited for it. I think, thank goodness that they stepped in with this sort of proactivity. I mean, some would say it's a long time coming, but I think it's exactly how the federal government should be leaning into this, as opposed to, I hate to say this, letting the marketplace just take it completely. We need some guide rails, especially when we're talking about healthcare.
Y'all who are following me probably already are tired of me talking about this, because I'm so excited about it. Because when I started working in digital health, like a lot of times when you're talking about concerns and things like that, they're always like, oh, nobody sues anybody in digital health, or no, we can do this, or it's not okay. So we're dealing with people's lives. I'm glad that they're getting some guardrails and they're implementing these things. And of course, they're just applying right now to the federal agencies, but we know everything that happens federally is going to trickle down into healthcare. So people need to kind of get their systems in alignment, their governance bodies, all of their policies in place, so that they can provide the standard of care that is within so many of the great things that they talked about. They talked about like how we need to have oversight. It talks about how we need to make sure that not only patients are safe, but there are equitable things that you're thinking about in the beginning, so that you will not perpetuate biases that are bound to happen. So I'm really excited about it.
Yeah, the additional executive order on clinical algorithms and how discrimination, you know, has to be proactively prevented. I'm taking part in a meeting next month on that, and I'm so excited that, well, I do think it's been a little bit slow, because we've been having these conversations about, you know, both ineffective and discriminating kind of algorithms, you know, GFR and all of those different pieces for some time now. Pulse oxes, I mean, how many examples do we have? And it's been a bit slow in the uptake for hospitals and the like to adopt, even though the data is clear. So the executive agenda coming down and the Office of Civil Rights actually stepping in and applying it across HHS's scope, I think is necessary. But, that falls on top of the AI work that we need to enforce some guide rails, and that there needs to be the proactive prevention of that sort of discrimination, not just by the users, but also by the designers. So, yeah, I'm excited for it.
Absolutely. And one of our listeners or watchers has a question, Dr. Michelle Donald, and she's saying she has concerns about data equity and the bias built into the algorithms. Do you have any thoughts on that?
I have been most nervous about that, to be honest, because the algorithms are only as good as the data that they're trained on. And again, going to our earlier points, if they're not accessing data for populations that are for a broad representation of different patient populations, geographic, gender, SOGI, race and ethnicity, then of course there's going to be bias. In fact, we can't avoid bias in every way. The goal is to mitigate that risk, and so therefore have as broad of a training on a data set for the algorithms to train and learn on. So yeah, that's actually my biggest fear, and where I think the transparency requirements around how algorithms are trained are necessary. That's one thing I'm excited about, the concept of scorecards around algorithms, and understanding around AI, and understanding kind of how they were trained and what went into it, that sort of transparency, so everyone knows, it's clear, and there can be hopefully appropriate decision making from there. I think that's a necessary step. But it's about mitigating. I don't know that we'll ever avoid full bias, but there's so many obvious spaces now that it can be avoided. So I think it's about having the right people in the conversations again, to raise the points, which is why I'm glad to be in the conversation with the Coalition for Healthcare AI, for instance.
Yes. Can you tell us a little bit about the coalition? There, like you said, there are so many popping up, and there are so many advisory boards, and a lot of the leaders from hospital systems and healthcare systems are coming together to collaborate, which is wonderful. So can you tell us a little bit about this one?
Yeah, I'm really excited, and I'm still so brand new with it. We are pulling together even the charter as well as the potential membership for the advisory board. But I'm co-chairing the Provider and Health System Advisory Board for Coalition for Healthcare AI. And the exciting part is that we're going to be able to advise the board, which is the actual decision-making body, on the many deliverables that CHAI is expecting to set up. It's a great coalition that involves ONC and other federal players. We're really going to be setting up the more detailed version of those guide rails, right? The executive order only said that there shall be, but now it's about really setting the rules. It's about really defining how we're going to score and how we're going to, further assure that there is transparency in process, both the development of AI as well as the use of it. I'm excited. I'm learning so much. So I am not the one to be asked about how this is all being pulled forward, but I'm definitely the one to have a lens from my clinical and operational experiences to be able to step in and think through how, especially primary care practices like Cityblock, would want to have some assurances around future AI and future services and future products. So I'm eager to learn more, first and foremost, but I'm excited. We just had our first meeting last week, where everyone convened out in California. We'll be convening again with the health conference in October, where we're going to dig a little bit more into details that the working groups are going to provide. I'm excited. I think we're calling it's called a coalition of the willing, right? And it's really about the concept that we all just need to come together and get off our high horses and stop thinking that we're going to create something anew, and just bring the collaborative spirit together for just the betterment of discovery and science. That's how I think of it.
I'm so excited for this. Like, it's something for those who are watching and don't know. I, aside from my health tech and leadership in that kind of realm, I have a digital health risk management firm, and it's something that we need policies on, we need guidance, we need to make sure that these organizations are held to a standard. So I'm very excited. I think that I'm going to be on a panel with the founder next month at Health Impact for those who are coming to New York in June. So hopefully we'll learn more about it there, and maybe have some conversations. Speaking of more about AI, but also other innovations, because Cityblock does a lot for the community. So can you talk about like how Cityblock is tackling some of these new issues with AI, as well as how you're innovating in healthcare?
Yeah. No, this was such a dream job for me. Having worked in so many environments where I learned about population health and community-based healthcare, not just community-based medicine, but broader healthcare, right? And really Cityblock leaning in, recognizing that we need to discover a different business model for underserved communities, and underserved, particularly Medicaid. I think there's a fair amount of need, obviously, for the uninsured. And I started my career in community health centers. And my residency program was in a community health center. So I get the importance of having services for a broader community, but we have to recognize the scale of Medicaid and how little attention is paid to innovation in that space, to improving outcomes, larger policy needs and the like. And so Cityblock really stepping in and recognizing that we can implement value-based care for this population, that it is a worthwhile opportunity, and that it can be tech-enabled to do so. In order to do real value-based care, we have to be able to find scale, to obviously optimize our workforce and optimize our services, and not be limited in terms of resources, but not be excessive either, right? And so that's where our tech enablement comes in. We have a tech stack that is both off the shelf as well as proprietary systems. We've included a great amount of machine learning in our data algorithms, because of course, taking care of a large population, we need to be able to stratify and understand and be as data-driven as possible. So we've built in a fair amount of machine learning into that. That helps us target which patients we're helping and what intensity of our model they need. Because I think one of the difficulties with primary care is, without really having data, we tend to treat every patient the same when they walk in the door. And of course, I'm speaking somewhat in jest. Of course, we're not treating them all exactly the same, but we're not stratifying our patients in a way that you would in an emergency room. We're very comfortable with triaging in emergency situations and recognizing that some patients need services first, right? And some patients need different types of services than others. For some reason, we don't implement that in the primary care setting. But in population health, you have to, right? We need to direct the resources to the right people at the right time with the right staff. And so that's where our data-driven approaches come from. That's where the machine learning has helped. Our tech enablement is, of course, we have an EHR. We switched over to Athena last spring after my very interesting stint into the EHR modernization world in the VA. That was interesting. I'll stop there. And we have a proprietary care management system that, of course, we integrate with Athena, and that is really the source of capabilities for our care teams to function in an integrated manner, be interdisciplinary. We're building a new engagement engine, new scheduling functionality, building on top of existing products. So we're not building everything anew, but the concept is, if we're going to reach more and more patients, and if we're going to continue to really target and improve health outcomes, we need to be efficient and effective with our care teams, and technology helps us with that. It's not about technology providing the treatment. We're not there at all yet. We're otherwise, for the right patients, very high touch and bread and butter primary care and doing it well. But the tech enablement helps us target the right patients, number one, and then prevents burnout of our care teams, number two, because they're not having to do that excessive administrative work that we all absolutely can't stand. And that, of course, deters a great number of our students from going into primary care, right? So I love being able to come up with more and more automation and really kind of care team friendly interdisciplinary opportunities so that it's still a very meaningful set of work for our teams, because we know, unfortunately, rampant throughout healthcare, that's not the case for so many care team members. So we're doing what we can. It's a mixed modality, tech enabled. It's got to be, because of the complexity of the patients that we're reaching. We need to have complex solutions. So we're going to be both high touch, high human, as well as tech enabled. We have to be. We have to approach it with every tool in our toolbox.
That's so fascinating and so appropriate. I think that's honestly what the goal of healthcare should be, right? Because technology is not a solution.
Like, it is not.
You should use it as an adjunct to help improve efficiencies, to allow people to work to the top of their licenses, and bring the joy back to medicine and the personalization back to care. Because that's actually how you reach patients and how you improve outcomes, and you keep them coming back, and you get them in alignment. Nobody just wants a text blast or a generic email. You have to personalize care. And the only way that you can do that is by getting to know patients and getting to talk to them, and not having to do all that extra stuff that keeps us up all night and angry at work.
Yeah, we're testing one of the ambient dictation systems now. That's going to be fun. Everybody's going to love that. We're looking at, patient summary opportunities. We're just going to keep adding in. But we know the strength is really in our care teams, is in our workforce. Our community health partners are the main, person of contact for our members. And there's no technology at all that will ever replace that. But if I can help my CHPs, not have to keep sticky notes, on their laptop to find the latest, partner to work with or something. If there can be a pad, an iPad that they walk around with, and how they educate their members in the community, in the home, of course, that's the direction we need to go. So it's about combining the technology with a caring workforce that understands the communities that we're serving.
That makes so much sense. And it kind of goes into what everybody is talking. I even hate kind of using this phrase anymore. We need to think of something else. Like, it's really utilizing technology to address the social determinants of health. I think people are using it as a buzzword now, when it's just common sense healthcare. Like, of course, people don't have access to medicines or hospitals or education, money, good housing, safe neighborhoods. They're going to be less healthy. And the people that are the less healthy are the people who are marginalized, like people, Black people, Latin people, Native people who are in rural areas. They're underserved, and they're underserved because they don't have the resources. So how do we get them the resources? And how do we, like you said, don't treat every patient the same when they come through the door, to ask them why they're not taking their medicine, why their diabetes isn't controlled, why they're in the lobby crying, and all of those kinds of things. You have time to treat the patients.
Yes, that's exactly it. I'm looking forward to more and more opportunity to bring more solutions into our practice. I am.
Absolutely. Now, moving to another aspect, because we're almost out of time, but I know just from looking at some of your background, that mentorship is important to you. You co-founded the Tour for Diversity, and a lot of programs are kind of looking for much more like different when it comes to the changes that are coming from, like, we had the DEI push of 2020 and now they're taking it away.
Oh, exactly.
So the Student National Medical Association recently released a call to action talking about dismantling medical school diversity, equity, and inclusion efforts threaten to increase the physician-patient workforce like gap. So with all of these changes that are going on in the medical school curriculums and landscapes, why do you think that it's very important for medical schools, residencies, and healthcare organizations to continue to prioritize diversity?
What I absolutely am astounded by is the fact that we actually still have to answer this question, Erkeda. Like that, the fact that we still need to refer to all the innumerable amount of data out there that diversity of the healthcare workforce is a solution to address health inequities. That having concordance, understanding, cultural humility between the carer and the patient is oftentimes a necessity for communications, for trust and engagement. And that unfortunately, we still see a significant separation, lack of trust, lack of satisfaction between care teams and patients. And again, the pandemic made it ridiculously evident as well too. So I think the arguments against DEI are very selfish. I think it's because individuals think that their spots are being threatened, number one, or that they themselves don't benefit from diversity, but we all do. And that they don't deserve a position any more than any other individual that we are affirmatively seeking to pull into our workforce. And that the biggest role for having a diverse workforce where there's inclusion, where everyone learns from each other, is that we can then take care of a patient population that needs us. So my work on the tour with SNMA and the like is fully in support of not just increasing numbers of Black and Brown physicians. It's about improving health outcomes for our patients that unfortunately the current healthcare workforce is not sufficiently staffed nor motivated to do. And I think that's the bigger problem. So if we get a workforce in there that looks like us, that comes from the neighborhoods that we do, to take care of the people in the neighborhoods from which we come, then we're going to see better solutions. But it's not happening now. We have care teams that are just staying in their ivory towers, saying they're doing community work, but it's just wholly inefficient when you're looking obviously at the outcomes that our people are facing now. So I don't think medical schools, residencies, and the like have any option but to prioritize diversity. And I think it obviously has to come from the top. And unfortunately, that's still lacking in so many different healthcare organizations.
Absolutely. Like, evidence has shown that people do better and have better outcomes with people who look like them. And yes, we've shown that there are just better engagement with your own community. Like we have at this point in time about 5-6% of medical professionals, not medical professionals, physicians who are doctors and who are Black, and this number has not changed since the 70s. So there was a little false alarm of the number going up maybe a few years ago with the boom of 20, but it's going back down. And we've seen, just even in this report alone and from talking to students who are out there, the treatment that they're getting, the pullbacks on their different things. I know SNMA is very dear to both of us, and I went back to my old medical institution and they were getting no support. They were getting no funding. They were not even told, like, attendees didn't want to attend their events. So this definitely has to change. We have to advocate for it, and we have to push, and we have to also bring in other people who don't look like us to push, because if we are making up 5% of the physician workforce, there's that 95% that needs to also treat patients appropriately.
There we go.
We need to
and that's where diversity within the workforce is actually helpful. The other 95% is actually receiving, additional education from having others that don't look like them, that don't come from their backgrounds, present in that, class makeup, learning right beside them, because hopefully they're sharing stories. I actually had an amazing trip down to Cuba this past January, I think it was, and got to meet at the Latin American School of Medicine outside of Havana. And part of their unbelievable opportunity is that they actually recruit from more than 100 different countries in each medical school class. And the students were talking about how much they learn from each other. So it's not just about the education that you're getting from the faculty, from your textbooks, the traditional sort of clinical medicine. It's about the cultural exposure that they were each getting, and that they then felt more prepared to treat different communities when they finished their training. I mean, I actually asked them, is there any way that you can start, this is the, data-driven approach to me. I was like, can you start to like publish? Like, are there studies that you could have of these? This is the argument for diversity right here. This is the argument. And no, it's not just about racial and ethnic. Religious diversity in their classes is celebrated. Cultural, the different countries, more than 100 different countries. Could you imagine that in your medical school? If you had that much exposure, I love what they're doing down there. And thankfully, they take American students. And I met some of the American students down there, and they were like, yeah, we chose this. This was not a backup. We wanted to be trained like this because American schools do not offer this same level of education.
Absolutely. One of my friend's sisters actually went to school down there and had an amazing experience. And I love that you mentioned, like, it's not just about like racial ethnicity and all of those kinds of things, because even when you think about it, being Black isn't a monolith. Like, if you look at historically Black colleges and universities, like, we are different. We have different insights. We have different backgrounds, different socioeconomic statuses, different viewpoints. So it's a diversity in experience and thought, but patients also have that. So we need to bring that together and learn from one another.
Exactly.
But we could talk about that for hours. But I want to address the question that's in the chat from Dr. Bradford. She asked, great conversation, loving it. Question, how does student and resident education need to adapt and modernize to be ready for the new health tech landscape that they're going to be putting out into practice? Do they need new curricula, new tools? Any suggestions?
Yes. And I'm actually excited to be exploring this. I can't say I have all the answers yet, but to explore this through a couple of new faculty appointments that I have to purposefully bring learners up to speed in work that I'm doing, and hopefully come up with some additional curriculum. I think medical students, definitively residents, need to be thinking about how they're going to integrate digital health into their practices. Need to be a part of perhaps some design sessions. Even need to be thinking about in a broader sense, how are we going to address the broader concepts of health through technology, as opposed to just healthcare and healthcare delivery? I think we have the opportunity to change. I hope that we take the opportunity to change how we think about training future physicians. I think we have done so in a very traditional medical model manner. So I think as our residents get more exposure to community-based opportunities, learning how to actually do virtual health, it is not the same as in-person care and just doing it on a screen whatsoever, and doing it in different settings so that we can see the technology in different settings and how you apply it to different communities. Again, I've been through correctional medicine, FQHCs, VA, now value-based. Like, when I talk to students, they're like, how do we get that opportunity? I'm like, well, this is part of my career. This wasn't my training whatsoever. But I think if we really think about adapting technology in all those different environments and getting out of this mindset that unfortunately academic medical centers put in us, that, that hospital-based ivory tower medicine is all there is. I think we need to expand medical school and residency training beyond just being accepting of technology, but just being accepting of broader concepts of how we can improve health.
Absolutely. Like, my friends and I talk about this a lot. When I go and talk to students, we talk about this. Like, there's so much, like, being a physician is just a part of who you are. It should not define who you are, but the type of physician can even change and evolve over different phases of your life. So you can do one thing 3 years, something else is not the time where you went and you sit in an academic setting or something for 30 years. Some people do, some people love that, but it's okay to change your narrative. And there are so many people who have come before, those who may be listening, who may be pre-meds or in med school or residents. Your career is going to change over time. Opportunities are going to come forward that you would have never imagined. I'm sure neither one of us thought we would be doing healthcare technology when we were in medical school or residency. Like, what is that? So time changes. Like, you have to adapt to the changes. There are a lot of institutions who are realizing that they need to have that change. I know I was speaking with a student who's at Harvard who's taking AI in medicine course and things like that. So they're popping up. So just looking and learning the landscape, it sounds like you're already in attending. So looking to see what is necessary to bring out to talk to your students and those kinds of things and what you can integrate.
Yeah.
So from a final question, what are you looking forward to most in this next phase of healthcare? Like, if you had a magic wand and you could change anything about healthcare, what would you do?
It's I have to be honest, it's not necessarily around technology. It is about, I really believe, number one, that we need to convert our system to prioritizing primary care, both through, payment rates, infrastructure support, and then converting the other resources within the healthcare system to be more community-based, as opposed to these tertiary centers, where, of course, we have the vertical integration and we have the specialization, and that, yes, has become necessary, but it's also pulling services away from where our patients live and where they're experiencing the majority of their lives. So if I had a magic wand, it would be probably implementing a full-fledged public health system the way Costa Rica does, where every community, every zip code has dedicated care teams, primary care, community health workers, where we have data across the board. And then we have a better evidence base to build those tertiary centers, know where to locate them, know how we can respond to chronic disease, acute needs, maternity care, and the like. I think right now it's all following the dollar, unfortunately. So I want a public health system. I think that has to be the chassis, a consistent one for every single zip code. I think that has to be the chassis to a successful healthcare system. And we're nowhere near that now.
It would be a priority. And as you've said, like, you've been mentioning different countries and the way that they practice medicine. And like, we all know, like, we are doing the worst in healthcare and we're spending the most dollars because we're throwing money at the wrong things.
Exactly.
I love how you said we have to prioritize primary care and ingrain that into people, because people are going to this specialty care and we need specialists. People are going to things that are disjointed and not connected. We don't even have interoperability where we can talk about different things, but we have to prioritize that, even with access to care, for and educating our patients on what to use. So they may have insurance, but you're like, okay, I'm a woman between the age of like 25 and 40. All I need to go to is my GYN. There's more to you than your vagina if you're a woman. So you have to get everything checked out. I know I have talked about this probably a bit much, over the past year or so. But I love that you guys are prioritizing Medicaid because my cousin, she's 30-year-old woman, last July was diagnosed with stage 4 lung cancer after
oh my goodness,
over 2 years to get worked up for endometriosis without a primary care. And no one told her to go to a primary care. And she developed a cough and she was going to urgent care and emergency room. And it got to the point where she had to go to the emergency room. And in DC, they diagnosed her with lung cancer. And they said, well, since you have Maryland Medicaid, there's nothing we can do for you. We're not even going to find you an appointment. Just go to the health department if you want to switch over to DC Medicaid or figure it out. So she called me and I got her in with Hopkins. But it was a battle, and she passed away in October.
Oh.
So 4 months.
So sorry.
Thank you. So we need to reform the system.
That's deplorable. Oh, my goodness.
Thank you. So
we need
I
to
like
reform the system.
That story because when I asked her, like when she was still with us and I was helping her navigate this, number one, people should not have to have a family member or a cousin to call people and pull strings to get them the care they deserve or to get a follow-up appointment from a deadly diagnosis. You just say, you figure it out. But number two, like there are so many people out there, and she just said, just share my story so it can help somebody.
Yes.
And I think that it's appropriate for people to realize, number one, go and get your wellness checks, even if you're feeling good or if something feels different. But number two, you have the power to impact your future and those that are coming after you. Like it is an election year. We love to talk about how healthcare isn't political and all those things. I hope in the last few years you've noticed that it is. So you have to vote because these things are impacting the things that you're able to do to live. In all of the different things. So yes, I told y'all I hate talking about the social determinants of health, but each of those facets, your neighborhood, the ability to have good food if that's healthy in your
water
house, how you can go out for walks, where you live, if you have asbestos or asthma triggers in your house and mold, like all of those things, the quality of care that you receive in your environment. So you won't have to tell your family members like I do, don't go get care in my county, go across the bridge. So these things are important.
Wow. Thank you for sharing that. Please continue to share her story.
Thank you.
Oh.
So I think we had such a great conversation. As we close, I just wanted to know if there's anything you wanted to share or any announcements or anything like that.
Nothing that I can think of. I'm sure there's a whole lot going on. You're going
to be doing a lot of work with the students and with the coalition. So just stay tuned. For those who are watching us on LinkedIn, you can leave comments after this has posted and I'll try to get back to them. I'm also going to share it on YouTube. Okay. So looking forward to chatting with you guys. Y'all know this is a newer thing, so you'll have a lot of more guests that are coming and talking about cool things in health tech. And then I'm going to have a few solo ones talking about some things about healthcare risk management and the cool things that are happening in digital health. So see you guys later.
Thanks, Erkeda.
You're welcome.